Hi guys, welcome back. We shall now be talking about a topic by the name of mitral regurgitation. One in the image you can notice that the chordae tendineae are damaged, which could be due to various reasons that we will discuss. But since the chordae tendineae form the structural support of the valve and they help the valves close rock solid, and not a single drop of blood leaks between the valve leaflets in you and me. But here you can see that the structural support is gone. You will also notice the undue doming or bulge of the mitral valve leaflet. So mitral valve prolapse is mostly associated with mitral regurgitation, and because of the defective coaptation of the leaflets here, a substantial amount of blood can leak from the left ventricle into the left atria of the patient, which would result in a characteristic systolic murmur. We will talk about the murmurs that are encountered in this condition, both in acute variety as well as the chronic variety, because in acute variety, suddenly the left atria will be exposed to a large amount of pressure. But when it comes to chronic, the left atria gets gradually adjusted to the continuous leakage of blood. So chronic MR and acute MR both have slightly different murmurs, which I'll explain to you. But the schematic diagram represents the fact that there would be a volume overloading on the left side of the heart, contributing to left-sided heart failure. Unlike mitral stenosis, which mainly causes the right ventricular hypertrophy, left ventricular failure is a presentation with respect to mitral regurgitation, and the acute variety can be life-threatening and can even contribute to death if surgical repair is not done. Let us therefore discuss what are the leading causes for one acute mitral regurgitation, and topping the list is infective endocarditis. You see, the septic process associated with infective endocarditis would damage the chordae tendineae, so the infrastructural support is gone, and that would result in a manifestation of acute MR. The second reason why this could be happening is that papillary muscles are gone. Now, why would there be a papillary muscle dysfunction in a patient or papillary muscle damage in a patient? Then can be understood by myocardial infarction, where the ischemic damage will destroy the papillary muscle. Since the support mechanism is once again gone, the doming of the valve will also occur. The leakage of blood from LV to LA will explain the extreme amount of pulmonary edema that will be developing in the patient. On a comparison scale, I want you to remember that posteromedial valve leaflet is more common as compared to anterolateral valve involvement. Now, why this difference is mainly because of the blood supply with respect to these areas. The posteromedial leaflet mainly has a singular supply or a single supply. You can understand that if any area of anywhere in the body has a single supply, if that critical supply is gone, well, that area is doomed. But if you have a dual supply, the chances of survival are relatively better. So the posterior leaflet primarily has a single supply, so it is more vulnerable to ischemic damage as compared to the anterior leaflet. The next cause for this could be mitral valve prolapse. One of the important causes of mitral valve prolapse is myxomatous degeneration of the valve. So either the word written might be MVP, or he can just write the word flail leaflet to signify the myxomatous degeneration that will be occurring in this patient. The fourth important cause for acute variety of mitral regurgitation should be remembered as trauma. You see, blunt trauma to the chest can contribute to death of an individual. One of the important causes why a punch, like a guy was punched in the chest and then he died. So blunt trauma to the chest can cause the heart to go into ventricular fibrillation. Like a punch to the heart can cause the heart to stop, or there could be a development of ventricular fibrillation. Therefore, blunt trauma contributing to death in a patient is referred usually as commotio cordis. I repeat my statement once again. There was a mixed martial arts match going on. A guy got, punched in the chest, or maybe a elbow to the chest. Like a MMA fight can be a no holds barred fight. So bare knuckle fighting can be there, and a solid punch landed at the critical time can contribute can knock out a guy flat and can contribute to commotio cordis, where you would be having a arrhythmia by the name of ventricular fibrillation. And then obviously, subsequently asystole will occur and the person will become pulseless and BPless would die. But if we are talking about blunt trauma to the chest in a car crash where the seat belt was not being used, so there are documentations that a person died because he developed pulmonary edema after a car crash. Why? Because the impact to the chest did not cause a cardiac tamponade, but it caused avulsion of the mitral valve leaflet, and the sudden rush of blood from high pressure chamber, left ventricle to left atria, will cause pooling of blood in the lungs and cause a pulmonary edema. So blunt trauma chest is also a worthwhile cause to be remembered. So four causes are infective endocarditis, endocarditis, myocardial infarction, myxomatous degeneration of mitral valve prolapse, and a blunt trauma. We will now talk about why would you be having a chronic presentation of mitral regurgitation, and one of the leading causes of chronic development of mitral regurgitation is again mitral valve prolapse. So MVP is mentioned in both acute and chronic. That's all for obvious reasons, right? It can occur gradually also. Then considering the Indian scenario with overcrowding in our country and recurrent sore throats being present all around the year, children would be having rheumatic etiology. And in rheumatic etiology, what happens is that there is a thickening of the valve leaflet, there is a scarring of the valve leaflet. So because these thickened and scarred leaflets are not able to coapt properly, therefore the end result would be mitral regurgitation developing in a patient. In fact, you could be having a combination of mitral stenosis and mitral regurgitation as well. The next cause to be remembered after this is subacute bacterial endocarditis. So acute bacterial endocarditis can definitely have a presentation of acute MR, whereas SABE can have a presentation of a chronic MR, very understandable. The subsequent cause to be remembered is congenital association. We read about what is called as a cleft mitral valve. This congenital cause, that is a cleft mitral valve, is encountered in patients who are having a ostium primum variety of ASD. Ostium primum variety of ASD is more severe than ostium secundum because there's a cleft mitral valve, so the blood of the LV will come into LA, so the shunting from left atria to right atria will be accentuated. So do remember regarding ostium primum ASD, which is also called as AV canal defect. Why AV canal defect? Because there's a cleft in the mitral valve, so LV pressure is transmitted to LA. Please appreciate, routinely in a ostium secundum ASD, only the left atrial pressure will be transmitted to right atrial pressure. But in ostium primum, because of the cleft in the mitral valve, the LV blood is also coming into LA, so the pressure gradient becomes relatively higher. So therefore, we find that ostium primum is more severe as compared to ostium secundum. Most of the time, the chronic variety will be occurring due to damage to the valve leaflets. So sometimes in multiple choice questions, you will notice the fact that he will use the word primary chronic mitral regurgitation. Primary basically means that there is damage to the leaflets of the valve. On the other hand, sometimes you could be reading the word secondary variety of chronic mitral regurgitation. Secondary would mean that the problem is not with the valve leaflets, but the problem is with the mitral annulus. You see, the annulus gets dilated. The blood can leak and the valve leaflets will still not be able to coapt, and therefore there's a leakage of blood. I'll try to explain this once again. You see, I'm saying there could be two reasons why the blood is leaking. One is that the valve leaflet is defective. Option number two is that the annulus itself is dilated, which prevents the valves from closing properly. And one of the important reasons why there could be a mitral annulus dilatation could be a cardiomyopathy, which could be ischemic or non-ischemic cardiomyopathy. So let's just mention it here. When it comes to chronic variety of mitral regurgitation, in MCQ he can use the word primary versus secondary. Primary means that there is an intrinsic problem with the valve. The intrinsic problem in the valve could be, like I have shown in this figure, a presence of degenerative mitral valve prolapse, myxomatous degeneration. So problem is in the valve, which is causing the blood to leak like this. But another cause could be functional mitral regurgitation. What I mean by functional is that the annulus gets dilated, so the valve leaflets are not able to approximate properly. So secondary will mostly occur in conditions like dilated cardiomyopathy, or it could be ischemic cardiomyopathy. You see, if a person is having coronary artery disease, like a double vessel disease, triple vessel disease, I asked the person to undergo a coronary artery bypass grafting, or I asked him to undergo a PCIV stenting, but the person did not follow my advice. So the ischemia in the heart is gonna contribute to micro damage in the heart. There would be micro infarctions developing in the myocardium, and gradually the damaged heart will start increasing in size. Another cause to be remembered is hypertrophic obstructive cardiomyopathy. Now, how hypertrophic obstructive cardiomyopathy contributes to this is because there's a subvalvular aortic stenosis. So there is a development of what is called as SAM. SAM stands for systolic anterior displacement of the mitral valve. In HOCM, there is problems with ejection of blood out of the heart with respect to not only the left ventricle outflow triad, but due to the gradient generated due to blood going out of the left ventricle, the pressure is also transmitted to the mitral valve leaflet, which is is displaced, resulting in leakage of blood from LV to LA. So what I'm saying is when the LV is contracting, it is sending blood into obviously the aorta where there's the problem. During the course of ejection, there's a problem which is subvalvular aortic stenosis, but the anterior displacement of the mitral valve simultaneously also contributes to the leakage of blood from LV to LA in the patient. So systolic anterior displacement of the mitral valve, it's traditionally called as SAM, is responsible for secondary variety of chronic mitral regurgitation developing in a patient. Then because in this condition there is a structural damage to the left atria, the left atria keeps on getting dilated because it is receiving blood from the high pressure chamber, the left ventricle. These patients can develop chronic atrial fibrillation. Chronic atrial fibrillation, the heart would be twitching, there is a dilated heart, so there would be a mitral annulus dilatation. A common thing that is occurring in all the secondary varieties is annular dilatation, whereas in the primary variety, the problem lies with the valve leaflets or the attachments under them, like for example, chordae tendineae are snapped because of the ischemic damage or due to rheumatic process occurring in a patient. If he says radiation results in mitral regurgitation, yes, and what radiation will do is it will mainly damage the valve leaflets. So causes like mitral valve prolapse or infective endocarditis, radiation should be remembered as primary because it's the valve cusps which are getting involved in the patient, and including the congenital variety association with ostium primum, which is also called as endocardial cushion defect. Then another rare cause of mitral regurgitation but worth remembering for MCQs is mitral annulus calcification. I'm writing this separately because this is not included either in primary and secondary. Here the problem is much more different from others because there's a mitral annulus calcification extending to the valve leaflets. This could result in both mitral stenosis and mitral regurgitation. So a condition which can result in simultaneous development of MS and MR in a patient is mitral annulus calcification, which could be occurring either idiopathically or after a rheumatic process occurring in a patient. Here, because I've talked about causes, so I would also like you to remember some associations. One of the associations to be remembered for MCQs is that SLE and rheumatoid arthritis patients, the valvular lesion that is associated is mitral stenosis. Remember my words, MR is related with ischemic cardiomyopathy or is associated with ischemic damage secondary to coronary artery disease, or it could be dilated cardiomyopathy, or it could be infective endocarditis. Mitral stenosis, obviously rheumatic is one of the causes, but SLE and rheumatoid arthritis are to be remembered. Then ankylosing spondylitis, that is HLA-B27 positivity, and syphilis are associated with development of aortic regurgitation. So because these are relatively less studied facts, they have been asked in the exam and I want you to remember them. Let's quickly go through this. Ischemic cardiomyopathy causes a MR. Why? Because there's a mitral annulus dilatation. Ankylosing spondylitis, because AS might look like, if you read it later, like aortic stenosis. So I'm clarifying here. HLA-B27 positive condition where you have sacroiliitis, you have a bamboo spine, and syphilis is where aortic regurgitation is associated. And then SLE rheumatoid arthritis can be associated with valvular region by the name of mitral stenosis. In rheumatology, I've taught you that in SLE and rheumatoid, there could be cardiovascular mortality, especially after 45. Both SLE patients and RA patients can die because of cardiovascular mortality. But today we have studied valvular lesion associated with them, that would be mitral stenosis in a patient. Once we get a hang of the causes of why this is happening in a patient, I'll just zoom in into this diagram just to get you a hang of what is happening here. That is, high pressure blood is being pumped from left ventricle into the left atria, whereas normally or traditionally this should not be happening. So I will now say a concept of physics, or rather fluid dynamics, which is written in the book, that is called as vena contracta. Meaning of the word vena contracta is, let us assume this is left ventricle, this is left atria. You can see a jet of blood racing from left ventricle to the left atria. So vena contracta in fluid dynamics represents the narrowest cross-sectional area of the leakage of blood. Like you can see, this jet of blood is having a bigger cross-sectional area initially, and then you are noticing that the cross-sectional area of the jet of blood is relatively narrow, and that is where the maximum velocity will be. This is a concept of fluid dynamics, that when the fluid is going to leak from a high pressure to low pressure area, at the area where there is the least diameter of the jet of blood, that is where the max velocity is present. So I'll write both the things. Where is the max velocity present? This is at the narrowest part of the regurgitant jet of blood. In fluid dynamics or in physics, we call it vena contracta. Now, why am I teaching you fluid dynamics? I should be teaching you internal medicine is because of the fact that we are studying regarding definition of severe aortic regurgitation. So what he says in Harrison is that you will say that the person is having a severe variety of mitral regurgitation when the diameter of this vena contracta, that is the narrowest part of the regurgitant jet of blood, because that's where the maximum velocity is. If this is more than 0.7 square centimeter, then we say it is severe variety of mitral regurgitation occurring in a patient. There are other criteria also, but this is one of them that will be always seen in any textbook that you read for severe MR. So that is why I've just spoken about it. Vena contracta, I repeat once again, represents the narrowest part of the jet of blood that is leaking from high pressure chamber to lower pressure area, and this narrowest part of the jet of blood will be having the highest velocity. More than 0.7 square centimeter is the definition with respect to severe mitral regurgitation in a patient. So once we are done with the causes for the disease, let's now just look at what are the criteria which are given in the textbook to describe the word severe variety of mitral regurgitation. One of the features is with respect to vena contracta diameter or cross-sectional area exceeding more than 0.7 square centimeter, as I just explained to you. The second parameter to be remembered would be regurgitant volume of blood, that is how much amount of blood is going from LV to LA. Then this criteria is same as that of aortic regurgitation. So remember, for both AR and MR, regurgitant volume, if it is more than 60 ml per beat, it signifies presence of the severity of aortic regurgitation, severity of mitral regurgitation. Instead of writing regurgitant volume, sometimes he might write the word regurgitant fraction, which should be more than 50%, 50, or he might write 0.5, either of the two. Or the last aspect to be remembered would be regurgitant orifice. You see, when the valve will be incompetent, there's doming of the valve, and separation of the valve. So the doming and the separation orifice should be more than 0.4 square centimeter. So there are two concepts that I've said. Vena contracta, as I explained to you, is the area where the jet is narrowest but has the max velocity 0.7 square centimeter, and the regurgitant orifice more than 0.4 square centimeter again indicates severe mitral regurgitation. So these are four criteria which will ensure that you will have to treat the patient. And what will you do for these patients would be one, MVRP, or you will be doing a MVR in the patient. When you read MV, it's mitral valve. RP stands for mitral valve repair. And MVR here stands for mitral valve replacement. So lots of time, because they use short forms in multiple choice questions, I thought that I should mention regarding the treatment aspect here only, that is MVP and MVR. And what should you do in severe MR or severe AR? We should go in for mitral valve repair. Why? Because if you will go in for replacement, you will have to put in a prosthetic valve. The prosthetic valve that will be put can be either a metallic valve or it could be made up of biological material, and prosthetic valves have their own complications. Like if you want to put the person on a metallic valve, then he might require a lifelong anticoagulation. There could be aspects of warfarin toxicity. Therefore, they don't recommend replacement. They say wherever possible, try to repair the natural infrastructure that God has given. So MVRP, that is mitral valve repair, is a more superior procedure as compared to mitral valve replacement when it comes to persons of mitral regurgitation, or might be simply written as valvuloplasty as well. I'll be drawing two diagrams before you to explain the differences in the murmur of acute mitral regurgitation versus the murmur of chronic mitral regurgitation. So just compare the two shunt diagrams that I make here. In the first one, I'm showing that the person suffered from a myocardial infarction, and you can see the bulge of the mitral valve leaflet occurring much higher than normal. Why this is happening is because the papillary muscles which support chordae tendineae are damaged, so the bulge is occurring in an upward direction. Second, in MI, the heart is turned, so there is a dilatation of the ventricular cavity. Mitral annulus is dilated, so again mitral regurgitation can be explained. What's happening here is that the left ventricle is suddenly decompressing into a normal pressure atria. You see, 5 minutes ago the left atria was working at normal pressure. Now because of the ischemic damage, there is leakage of blood occurring from the left ventricle to the left atria. In contrast, in the second diagram, I will draw the heart relatively bigger. Why? Because there has been a gradual onset, left ventricular enlargement occurring in this patient, and that will affect the right side also. Like we can take this to be a person of rheumatic heart disease or a person of dilated cardiomyopathy. So dilated cardiomyopathy is a progressive condition. So the heart has been shown to be relatively dilated, and in this case also the blood is leaking from the left ventricle to the left atria, but the left atria pressure in this case is elevated. Why? Because it has been exposed to this jet of blood for large number of months and years. The fundamental difference between the two diagrams that I've tried to show is not only with respect to the size of the heart, but I have also tried to represent here that in the first one, the ventricle is decompressing into a normal pressure atria versus a atria that is already compliant. So just for representational sake, I can show this left atria to be structurally relatively dilated as compared to what it normally should be. This will explain two things. One, the structurally dilated left atria can be having atrial fibrillation development, and second, the left atria is having a relatively higher pressure, so it is already used to high pressure circulation. Now, in acute mitral regurgitation, the pressure difference between the left ventricle and the left atria will suddenly become very high, so due to which the pulmonary edema will be a sudden onset and the chances of death of the person will be increased. I mean, this person can die in the next couple of hours unless and until you use proper vasodilators and diuretics for the person. The murmur that is heard in acute MR is a early systolic murmur. It dies down much before S2. The term is ESM, but you are not supposed to confuse this with ejection systolic murmur. Ejection systolic murmur is heard in valvular aortic stenosis. Here I am using the word early systolic murmur. In contrast, when it comes to chronic mitral regurgitation, the murmur is relatively longer lasting. Why longer lasting? Because the disease is a progressive condition and the peak of the murmur is rather, I would say, toned down. There's more of a plateau appearance of the murmur. This presentation where the murmur is relatively longer duration, primarily because of one, the longer duration of the disease, the pressure gradient has been gradually increasing in this condition. The pressure is not peaking suddenly, it's more of a plateau, is called as a pansystolic murmur. So we have pansystolic murmur written in literature, and then we have written ejection systolic murmur. Both of them are different presentations with respect to early and chronic. I also don't want you to confuse this with late systolic murmur, which is seen in mitral valve prolapse. I have currently shown presence in green of mid systolic clicks. Mid systolic click is due to the upward bulge in MVP. If a person is having isolated mitral valve prolapse, the murmur is rather late systolic. So you are now aware of the fact that early systolic murmur is a feature that is seen in acute variety of mitral regurgitation. Late systolic murmur is a feature that is seen in mitral valve prolapse. And the third one that you need to remember is called as ejection systolic murmur, which will peak bang in the middle of the systole and then the intensity would go down. So in color purple that I've represented before you is called as a ejection systolic murmur or a crescendo decrescendo murmur. This would be encountered in patients of valvular aortic stenosis. Because of the overlapping terminologies, very closely matching words, I want you to be very thorough with this, so I'll make you practice once again. Early systolic murmur is a feature of acute MR. The pressure gradient is the reason why you have a sudden peaking and then obviously the pressure comes down because it is decompressing into a normal compliant atria. Whereas the compliance of the atria is already more in persons of chronic MR because the atria is used to continuous leakage of blood that has been happening for a long duration. So the pressure will not rise very suddenly. It's more of a plateau, so we call it a pansystolic murmur, but the duration will definitely be longer of the murmur. It would be present all through the duration of systole, so we also call it a holosystolic murmur. Then remember, late systolic murmur for mid systolic click and ejection systolic murmur for aortic stenosis. We can practice this repeatedly so that this becomes a permanent memory for us, because as I said, most of the time when it comes to cardiovascular system, especially valvular heart disease, they try to trick us with the terminologies in the murmur. I mean, that is the nemesis of the discussion. I mean, if you are good with the murmur part, you can work out the valvular heart disease primarily. So let's now look at the subsequent subsequent information and practice this again. So the symptoms that develop in the patient would be ranging from fatigue, paroxysmal nocturnal dyspnea, orthopnea. Those would be the standard opening lines to describe a person with mitral regurgitation. As the time will progress, in these many patients, you will also start having features of right-sided involvement. So hepatomegaly, development of ankle edema, elevated JVP, and even a development of tricuspid regurgitation could be written in the question. This tricuspid regurgitation is functional. It is secondary to the dilated heart, like in a dilated cardiomyopathy patient. In these patients, you will also be able to read regarding development of palpitations. That is because the left atria is structurally dilated. It is structurally dilated. The dilated atria will start developing atrial fibrillation, and therefore anticoagulation in these patients will be required on the basis of CHAD S2 VSC score, because otherwise embolic stroke manifestations could be occurring in the patient. Both mitral stenosis and mitral regurgitation are valvular lesions that cause structural damage to the left atria. The dilated left atria sets up an abnormal rhythm, and the twitching that is present here can create clots in the left atrial appendage, and if any one of them, even a single one of them, goes to the brain, it could kill the person due to development of embolic stroke in a patient. Based on the clinical history, you will definitely realize that there's a problem with the left side of the heart. This could be even after event of MI or endocarditis, or it might be a known case of mitral valve prolapse who has deteriorated now. Let us now look at the examination findings that would be seen in these patients. On physical examination, you will notice that the blood pressure in these patients is initially normal. That's because the left ventricle, in chronic variety I'm talking about, left ventricle failure is a presentation of acute, then the BP will obviously fall. But in the chronic variety of mitral regurgitation, the BP initially will be normal in the patient. On palpation in the patient, you will be able to feel a thrill. This thrill will be best appreciated at the apex. Meaning of the word thrill is that there is a palpable murmur, and you will also notice that the apex beat will be slightly displaced in the patient because there is a hypertrophy of the heart that can develop in these patients. The apex beat character in this person will be hyperdynamic. Hyperdynamic is different from heaving. Aortic stenosis has a heaving character where the impulse will hit your finger and lift your finger. Hyperdynamic means you will just feel a forceful impulse hitting your finger, but it will not lift up your finger. I repeat again, heaving is forceful and lifts up your finger. This is just a forceful impulse that you can feel under your finger. So hyperdynamic character of the apex beat will be felt, and you will also notice that there is a displacement of the apex. Normally we are able to feel the apex at fifth intercostal space 2 cm medial to the midclavicular line. Here the apex would be displaced relatively inferiorly in the patient. So most of the time when you read the question, the features of left ventricle failure, development of thrill at the apex, you will start getting a hang of that what are the presentation or what could be the reason behind the presentation of this patient. Let us now look at the auscultatory findings of this patient so that we can remember or evaluate the patient better. On auscultation in mitral regurgitation, the first heart sound is usually soft. Do remember, loud S1 is a feature of mitral stenosis and soft is a feature of MR, and the explanations for that I've given in the topic of heart sounds, so you can go through that. And the simple logic is transvalvular gradient is enhanced in mitral stenosis, so you have a loud S1 here because there's a leakage of blood, so the transvalvular gradients are reduced, so therefore there's a soft S1 developing in the patient. When it comes to second heart sound, the A2 and the P2 will be affected in the following sense, that in these patients the A2 part will occur relatively early. Why that is so is because of the fact that now less blood will have to go out of the heart. I'll just show you the diagram that I drew before you earlier. In patients of mitral stenosis, when the blood has to go out of the heart, majority of blood is already leaking to the top. So because some blood from the left ventricle is already decompressed into the left atria, the amount of blood going out to the left atria is lesser. Less blood will take less time to go out. So in these patients, there will be a development of a early A2. So I'm shifting this line slightly to left to say that patients of mitral regurgitation have a early A2, and therefore they have a wide split second heart sound. This will definitely be impacted by respiration. That is, our respiration will cause P2 position to anyway change with respiration. So we will call it a wide variable split second heart sound. It's a standard feature to have a wide fixed split in AST, but when it comes to VSD, when it comes to mitral regurgitation, we have a wide variable split second heart sound occurring in a patient. Since the left ventricle in this patient will get dilated because there's a turbulence in the heart, there is a rapid ventricular filling occurring in the patient, the heart is getting dilated. It's all a ongoing process because all the blood of LV that goes to LA, that has to come back from LA to LV also. So there's a volume overloading the left ventricle. So third heart sound can be present in the patient, and then you will be able to hear a murmur also. In these patients, you might even be having a diastolic murmur. Now, don't be surprised at the words that I'm saying because mitral regurgitation should be having a systolic murmur. Already made you practice multiple times it has a systolic murmur. Now, why am I talking about a diastolic murmur is because all the blood of LV that will go into the left atria has to ultimately come back into the left ventricle. Look at this shunt diagram. I'm showing rather diastole occurring here on the right side, perfect. But on this side, what I'm saying is that patients with chronic mitral regurgitation are already having a dilated left atria, congested pulmonary circuit, and this blood which is now accumulated in the left atria ultimately has to come back into the ventricles. So if you look at the shunt diagram here, I have shown a normal transit of blood from RA to RV during the phase of diastole, just like it would happen in you and me. But in these patients, the more volume of blood when it goes across a normal mitral valve leaflet, I am saying the fact here, normal with respect to at least the diastole component. During systole, they are not able to coapt, so there's obviously a bulge, they tend to leak. But during the phase of diastole, this extra volume of blood, when it travels to the mitral leaflets, it again results in development of a flow murmur. The diagram here is representing diastole, and this is diastole of a person of chronic aortic regurgitation. Why we are studying this is because traditionally, we read about systolic murmurs in mitral regurgitation. I'm teaching you diastolic murmurs. So this is S1, S2, S3 being heard in the patient, and then you might be able to hear a diastolic murmur in the patient, that is a MDM. When you read the word mid-diastolic murmur, the first thing that comes to your mind is mitral stenosis. In mitral stenosis also I've explained mid-diastolic murmur, but that starts with a loud opening snap. Here I did not mention any opening snap. I simply said this is a flow murmur of all the blood that went up from LV to LA. It ultimately has to come back from LA to LV. So that results in development of a MDM in the patient. The traditional murmur is like this. PSM, pansystolic murmur with a plateau. As I explained, P is plateau, pansystolic murmur. And then a MDM, a mid-diastolic murmur, which is a flow murmur occurring in the patient. Do not be surprised if you read mid-diastolic murmur present in patients of mitral regurgitation. It indicates the severity of the disease because as the disease will progress, more blood coming into left atria has to come back. So MDM developing in this patient indicates progression. It indicates severity of the disease. Let's now look at the workup of these patients. One of the basic tests to be done in these persons is ECG. Since it's a cardiology case, I'll obviously say investigational choice is echo. But when you do ECG in these patients, you will get a very characteristic finding in the P wave of the patient that you could be having a notch in the P wave. You normally don't have a notch in the P wave, but here the notch is present and the duration of the P wave is turning out to be more than 120 milliseconds. This is because of the fact that there is a structural dilatation of the left atria. Normal configuration of the P wave would be in the range of about 3 small squares, 120 millisecond. Here there's not only a notch, but the duration is also more than 120 milliseconds. So the terminology that I'm gonna make you remember here is called as P mitral. I also want you to notice that in some patients you could be having, especially COPD patients, peaked P waves where the duration of the P wave is much more than normal, more than 2.5 millimeter in the limb leads or more than 1.5 millimeter in the chest lead. So if the vertical height of the P wave is much more than normal, then we tend to call it P pulmonale. So 3 abnormalities of the P wave that I want you to remember is 1, P mitral where the duration is relatively more than 120 millisecond. P pulmonale where the vertical height of the P wave is more than 2.5 millimeter in the limb lids of the patient. And in case you get a question of variable amplitude of P wave, there is a tachycardia, like he says a COPD patient, there is a variable amplitude of the P wave present that indicates a arrhythmia by the name of multifocal atrial tachycardia. So do remember my words. P mitral indicates left atrial chamber enlargement, pulmonale indicates right chamber enlargement or pulmonary artery hypertension, and variable amplitude of the P wave indicates a multifocal atrial tachycardia in a person. So ECG of these patients will reveal evidence of left axis deviation and findings of P mitral to be primarily present. We will now look at the X-ray findings of these patients. On the chest X-ray, one, you can notice a fullness of the left heart border in the patient. You can notice that the cardiothoracic ratio of this person is substantially increased. The next thing that you will notice in the patient will be a double atrial contour. You see, left atria does not form the left heart border. Left atria is present sandwiched between the tracheal bifurcation of the cranial angle. When the left atria will become bigger, the enlarged left atria will increase in size eccentrically, so it will push the right atria, and pushing of the right atria will result in development of what you can see as a double atrial shadow in a patient. So the second finding of this person is a double atrial contour. I repeat my statement: double atrial shadow, double atrial contour is due to left pushing the right. It signifies a displacement of the right atria secondary to the enlarged left atria of the patient, and the CT ratio of the patient is very, very significantly enhanced. So the X-ray findings are: one, a finding of cardiomegaly with a double atrial shadow, so the disease starting from left and involving the right side of the person as well, plus a bit of pulmonary congestion can be noticed, especially the perihilar shadows in the person are increased. Then a very interesting finding that is described for this patient is with respect to the fact that this is the trachea. You see, we have a trachea, then a trachea bifurcates. We have a cranial angle. So in this case, what happens is that the cranial angle will be increased. Normal cranial angle is 60 degrees to 70 degrees. Here it will be increased. Why? Because the left atria is sandwiched between the cranial angle. So it will increase and will separate or increase the amplitude of the angle. So the term that is used to describe this angle that comes up, the left atria on a lateral view on an X-ray, you can notice that the left atria is rather situated posteriorly. So in fact, one of the most posterior structures in the heart is going to be the left atria, and right ventricle is rather anteriorly located. So what I'm saying in the patient is the enlarged left atria will increase the cranial angle and will result in a X-ray finding on a lateral view that is called as walking man sign. So two things in X-ray. One is in the AP view that I said that you will be able to notice a double atrial shadow, and second is on a lateral view, which is a very classical name, walking man appearance, or a walking man appearance indicates separation of the cranial angle in the patient beyond the normal 60 degrees. Normally it's an acute angle. It can go up to right angle primarily because of the enlargement of the size of the left atria. The AP view of the patient will be revealing evidence of pulmonary edema. Apart from cardiomegaly that I've highlighted, pulmonary edema, curly B lines can be present. So if you add up all these facts together, they all signify that there is a decompensation occurring with respect to the left side of the heart. Normal cardiothoracic ratio is 0.5 for adults and 0.6 for children. So in these patients, cardiomegaly is a presentation. Once echocardiography has been used to identify the severity of the disease and the presence of the disease, obviously, it would be time for treatment for these patients. If the question says, what is the best treatment for acute mitral regurgitation? Then because it's a life-threatening presentation of pulmonary edema, for management, you will have to use diuretics, loop diuretics like furosemide and vasodilators. We will have to use vasodilators like sodium nitroprusside for these patients. Traditionally, we study about sodium nitroprusside in management of hypertensive emergencies, but today I'm saying in a cardiology patient who's having an acute onset sudden decompensation with left ventricle failure, I will use nitroprusside because the stress on the heart significantly has to be reduced. For management of chronic mitral regurgitation in a patient, in both symptomatic patients and asymptomatic patients, the best way for management would be mitral valve repair, which will be written as MVRP. Now, the advantage of mitral valve repair over mitral valve replacement is that the post-operative morbidity part is reduced, because most of the time in mitral valve replacement we use a metallic device. Therefore, lifelong anticoagulation might be required in the patient, and aspects of warfarin toxicity can be there. Most of the time, the mitral valve repair procedure that is done is development or deployment of an annuloplasty ring, or sometimes we might have to develop new cords or new chordate tendineae, or they might even be chord transfer so as to ease off the pressure on the undersurface of the valve leaflet and ensure better compliance. Whenever he says the word symptomatic patient of chronic mitral regurgitation, which is of the severe variety, then obviously this is the best answer. Suppose in the question he begins by saying a person is asymptomatic but he's having severe variety of chronic mitral regurgitation. Well, it is highly unlikely that a severe MR will be asymptomatic, but after all, a MCQ is a MCQ. So if it's a asymptomatic patient, we will obviously check the left ventricular ejection fraction, and we will also check for left ventricular end systolic dimension, ESD's end systolic dimension. In case we find that the ejection fraction of the patient is less than 60%, normally 65%, I'm saying asymptomatic person, so hovering around 50 to 60, so it is less than 60, and the left ventricular end systolic dimension is more than 40 millimeter. That's because the blood of the LV is going to LA and is coming back to LV, so the ventricles are getting dilated, so failure can occur very soon. So even in an asymptomatic chap, if these parameters are mentioned, then again mitral valve repair is required in the patient. I repeat my statement, symptomatic patients or severe will anyway require a mitral valve repair superior over a mitral valve prolapse. Asymptomatic chap with left ventricular end systolic dimension more than 40 indicates left ventricle will decompensate very soon, so mitral valve repair would be required for the patient. A new approach for management of this patient is a transcatheter mitral valve clip. Now earlier we were doing transcatheter procedures for aortic valve, but now we have evolved further and we can even take care of MR by doing a transcatheter position. This transcatheter mitral valve clip is introduced via the venous access. So I will be, let me say, taking access via the basilic vein of the patient. From the basilic vein we enter into the superior vena cava, then we enter into the right atria, then we puncture the interatrial septum, and then you can see the guide wire coming in position in the left atria of the patient. We will guide this clip at the junction of the left atria and the left ventricle, and then this clip is positioned in such a fashion that the regurgitation process will not occur. You see, we are simultaneously doing a transesophageal echocardiography in the patient. So when the clip is being deployed, we will basically place the clip at the area where there is the highest pressure gradient recorded. There is a continuous leakage of blood occurring from LV to LA when the heart is contracting. This surgery or procedure would be done at on a beating heart. So initially there is definitely a leakage of blood, but once the clip is in place, and the advantage is we can adjust the position of the clip so that we can reduce the leakage, and therefore once the clip is in place, you can see that the valve leaflets are now in a fashion that the leakage of the blood from LV to LA is not going to occur like normal person. So transcatheter mitral valve clip is the, I would say, in thing nowadays, as an interventional cardiology has I would say increased by leaps and bounds in past couple of years, and this is a new treatment which is available for management of these patients, but only in selected centers. And where would you do it? Obviously any patient who's symptomatic severe valvular mitral regurgitation. If it is mild to moderate, as I said, most of them are asymptomatic, but even if it is asymptomatic and the left ventricle size is increasing, we should tell the patient that he can decompensate soon. So it's a good idea to go in for a surgical maneuver in the patients. So that's the treatment part, guys, that I want you to remember for this topic. It's pretty a straightforward one, and most of the time I would usually find people messing on the murmur part. So I'm just gonna say it for one last time, just hear me out. You would have in acute AR early systolic murmur. In case it is chronic, it would be pan-systolic murmur, and you could also be having a mid-diastolic murmur after S3 present in this patient. That is a flow murmur, because all the blood that went from LV to LA has to ultimately come back. So keep studying, guys, keep hammering, and you would definitely come out with flying colors. I would like you to listen to this part very, very thoroughly, especially the valvular lesions, because if you're good with this, then the remaining part of cardiology and internal medicine also becomes interesting. Thank you so much.